Good morning, everyone. My name is Elene Tkabladze. I'm from the Internal Medicine Department from Berlin, Germany, and I will present today a unique case of the first documented use of the Wrapsody stent graft for the treatment of nutcracker type of pelvic congestion syndrome. This case is challenging for our department and also offers promising results. This case is about the 30-year-old female with two pregnancies and two live births who came to us with a recurrent left flank and lower abdominal pain since 2015, and the pain worsened after the birth of her second child, 2019. The pain included convulsive spasm, worsened after prolonged sitting and standing. No systemic or gastrointestinal symptoms were found. Socially, she is non-smoker, occasional uses alcohol, and medical history with oral anticontractives prior to the first pregnancy. Started treatment for the acne with isotretinoin in October 2021. Past medical history included sinus surgery for nasal polyps. 2011. On her physical examination, patient was in a good general health. As you see, the vital signs were normal. Cardiovascular, gynecological, and gastrointestinal checkups were unremarkable. Laboratory findings: liver function, pancreas function, kidney function, as well as small blood count. We are all within normal limits. We also did an ANA-ANCA test. ANA tests were lightly positive, 1 to 80 titer, and ANCA tests were negative. Urine examination showed us proteinuria, microhematuria, and lightly decreased urine-specific gravity. So the next step included diagnostic imaging. First, we did an ultrasound revealed enlarged left kidney with dilated appearance, and the left renal vein was congested proximal to its passage through the aorta and superior mesenteric artery. The next, we did MRI, which confirmed the ultrasound findings, and CT scan showed the persistent dilatation of the left renal vein and left ovarian vein with the caliber change of the renal vein between the abdominal aorta and superior mesenteric artery. Here you see the CT scan, the compression of the left renal vein between the superior mesenteric artery and aorta with the arrow. So the diagnosis of nutcracker syndrome was confirmed. The pelvic congestion syndrome may arise from the different pathogenesis. Here you see the three types of pelvic congestion syndrome. The first type is most commonly reflux in the left ovarian vein and in internal iliac vein. The second type is nutcracker syndrome, which is our case. The external compression increased the venous pressure transmitted to the ovarian vein congestion, and the second type is rare case, May-Turner syndrome, compression of the left common iliac vein. You can see here the schematically pelvic congestion syndrome pathogenesis. The first type is reflux of the left ovarian vein. The second type, compression of the left renal vein due to the entrapment between the superior mesenteric and the abdominal aorta. And third case, the compression of the left common iliac vein. So to confirm our diagnosis, we did the phlebography of the left renal vein and left ovarian vein, and we implanted the Wrapsody stent graft. At the image you can see the ovarian vein insufficiency and pelvic varices. So the Wrapsody stent graft is a unique three-layered cell-impermeable endoprothesis with maximal radial resistance force typically used for dialysis shunts. At this picture you can see the Wrapsody stent graft inserted to the left renal vein. Treatment medication, we started with the aspirin 100 milligram once a day, and you can see the ultrasound results after 2 years post-procedure. The patient has no symptoms more than the excellent stent function confirmed on follow-up. This case demonstrates the successful use of the Wrapsody stent graft as a novel, safe, and effective treatment of the nutcracker syndrome in pelvic congestion syndrome. There are advantages of this endovenous approach, like minimally invasive and effective in revealing the venous compression, but lack of the long-term data and further research should be done to verify the durability and effectiveness of the Wrapsody stent graft. This encouraged further investigation to confirm the long-term outcomes and broader applicability. So here's my references, and thank you for your attention.
Thank you. And now
I do have still the microphone, so I will ask the first question. If we order pelvic ultrasound in a person who has non-specific symptoms, would you know how often the radiologist would look for this particular condition? I wonder how often it goes undiagnosed.
Actually, this patient went first to the GP, and they did an urine examination, and after they saw microhematuria and proteinuria, they revealed the patient to the hospital. They mostly saw young patient with a left flank vein who, at this case, was like for 2 years. They are not coming so often at the hospital, so I think it's not so often done at the praxis.
Well, thank you very much. Your patient suffered pain for 4 years, and you treated this pain. She must have been very grateful. The question here is two-part question. Number one, did her flank pain and her pelvic pain both disappeared after this stent? Number two, is it just the compression of the renal vein that you did? What about the ovarian vein? Still compressed or not? Or was it just the renal vein compression caused her pain, you think?
We think that the renal vein congestion caused the left flank vein, and due to this congestion was outflow in the pelvic system, so it was also due to the left renal vein, we think, the abdominal pain. And the patient is doing also checkups every 6 months at our hospital, and she wasn't having any symptoms after the stent graft emplacement, but now she is pregnant. It's her third pregnancy, and now she feels like a left flank pain again.
Okay. And lastly, why is it called a nutcracker condition? I've heard of nutcracker esophagus, but not nutcracker. Why is it called nutcracker?
I think because of the congestion, the vein varices and the ovarian vein, it looks like that, and that's why.
So two last questions, Dr. Tkabladze and Dr. Perry Baker over there.
Further to Dr. Pange's point, it's just the extrinsic compression of a venous structure, in this case the SMA, over the vein, like in May Thurner. I mean, this is a nice presentation of a complex and sometimes controversial condition that's getting a lot of attention lately. How did you handle the prevention of thrombosis in the stent, short-term and now during her pregnancy?
So we initiated therapy with antiplatelet aspirin, but for now we also took with the hematologist. For now we don't prefer to give anticoagulation.
Now she's pregnant. Are you going to change anything?
We have a next appointment in June this year, so we have to discuss about it.
Okay, Jim, would you comment on it?
Well, my point is that you've got a device in the venous system. You're activating the extrinsic pathway, tissue factor, and all that. So you're driving a coagulation process. So one might argue that there's a rationale for not an antiplatelet, which is a high velocity kind of situation, but an anticoagulant for long-term prevention of stent thrombosis. And especially during pregnancy, where you're going to have a gravid uterus and other factors that will create a further prothrombotic state. So, when you may see her, you might bring that option up a little more forcefully.
Thank you, and Dr. Carrie Baker.
Thank you. So thank you, first of all, for presenting a case showing that women with chronic pain shouldn't be ignored. So we know that women's pain is commonly ignored or misdiagnosed. So a great example of why we should look for pathology. A question about Maytherna, because this was type 2 that you stented. The type 3 Maytherna actually is pretty common if you look for it. We run a DVT clinic, and it's one of the main differentials for unprovoked left DVT in women, and the more you look for it, the more you find it. But our vascular colleagues are really disinterested and say there's nothing that can be done. Do you think this changes things? Do you think the type 3, the Maytherna, should also be offered stenting like this? And is there any evidence for that?
I think it depends the symptoms. Like if the patient has the mild symptoms, first we give some NSAIDs or hormonal medication, and also oral contraceptives to decrease the estrogen level may be used. And then if the patient is having like nutcracker or Maytherna syndrome, the symptoms are like for years, and it's we have to discuss the stent, or also there are possibilities for coiling, and yeah.
So
Well,
yes, we should push our vascular surgeon colleagues more. Is that the answer?
Okay, thank you very much. We have to move on.